earned his bachelor's degree in microbiology at Texas Tech University in Lubbock, Texas. He then earned his medical degree from Texas Tech University Health Science Center. Dr. Purtle completed a residency and fellowship at, is it Christianshof family? How do you say that? Okay,
Yes.
great. A medical residency program in Corpus Christi. He is dedicated to providing the best patient experience for our patients, and this includes a personalized approach to your medical care and providing you with the education and preventative tools you need to improve your health and well-being. I think that's what WellMed is all about, isn't it?
It is, it is. So thank you for having me on.
Absolutely.
And what I do and why I love what I do and what I can do to help. Especially during these very trying times, right?
Yes.
So again, I'm Dr. David Purtle. I am a geriatric medicine physician. I am primarily trained in family medicine, so I started with all ages and fell in love with the practice of geriatrics and did a fellowship, so I am specialized in the care of those that are 65 and above with multiple chronic health needs, as well as those with more complex health needs. I started with Wellmet in 2015. Today is, as it turns out, the 5th anniversary of my time with Wellmet. So I've been here exactly 5 years today. And it really has been an honor to be part of a company that does for seniors what they do. So Wellmet is a different kind of practice than what a lot of people are used to. With Wellmet, the focus is not so much the revolving door. The patient, coming in, you talk about a problem, and then you leave. Now, here, let me see what I can do to help. Is that any better?
No.
Okay. So I hear, my understanding is that there is some audio difficulty. Let me try something a little different. Not sure what I can do with this. I think we had solved some of the other stuff last time.
Yeah, we did something with your laptop and the microphone.
We opened it up. Let's try it again now and see if it's going to be what it tried.
Okay.
What about now?
Talk a little bit more.
Okay. So are you able to hear me a little bit better now?
Yes, we can. Absolutely. That is better.
Okay. Very good. Okay. Thank you so much. And thank you for bringing that to our attention, right? You want to be heard. So to reiterate some of that, I've been with Wellmet for 5 years. Wellmet is different than what you may be used to with a lot of the practices that you may have gone to in the past. We do offer a more holistic approach to medicine. Fading out again. I apologize. Maybe it's just getting closer to the computer, so I'm going to angle this a little bit differently. Did that make a difference?
I think it helps a little bit.
Helps a little bit. Okay. All right. Very good. Thank you. Thank you, Ms. Nelson, for that. Okay. Let's see what I can do to adjust there. Okay. So we do take a more holistic approach to medicine, and what that really entails is more in a preventative focused way. So instead of coming in and speaking for your problem for maybe 15 minutes, our visits can often go 30 minutes, 45 minutes, hour longer, because we really want to address all the health needs that are there and not miss big things. We want to address things while they're small before they become huge issues, and really to identify all those little foci of potential issues that can become problematic in the future. So we know that during these times, it's very difficult to get to a physician or any healthcare provider for that matter. And we, along with the rest of the world, are having to find ways to innovate around that. And one of the ways that we're doing it is exactly as you are seeing me now, through telemedicine and using that technology. But in the spirit of what we do, we always go one step above what anybody else would do. So yes, we have the telemedicine. If you're lucky to have a cell phone, a smartphone, a computer with a camera, great. But a lot of folks do not have that, or they don't know how to use that technology. And we have means for that too. So we have these devices, we call them grand pads. They're like iPads, but they've got two buttons. One is answer and one is hang up. So it makes it very simple. They work off a cellular network. And we have individuals that will drive to a home and deliver these pads for me to be able to call. So there's really not a person that we cannot reach. We have patients that are homeless, and we're able to make sure that they're taken care of that way. So really, this has opened up this vast network to be able to meet the needs of people as this is happening. And the other issue that's been happening, of course, and I'll address the elephant in the room, it's COVID, right? It's all you hear about when you turn on TV, and that's got a lot of people thinking, right, well, you know, basically every news station that I turn on says that if I go outside of my house, I may die. And while there may be some very serious risks, there's more risks that are happening right now for people that are not getting their health care needs addressed because of their fear of coming to the doctor. So we're hoping by being able to utilize some of this technology that is at our disposal that wasn't here 20 years ago, 30 years ago, that and we don't miss those big heart attacks or those strokes or those family issues that are building and in fact worsening during these times. So we want to make it to where somebody has every opportunity to be able to see me on there. So again, you know, thank you for hearing what we do, why we do it, what we're about, and giving me a little bit of a taste of that. So my understanding today is that I'm here to talk about dementia. And this is a topic that gets brought to me very often, usually in the form of a person coming to me saying, you know, doc, I'm concerned because I'm not remembering things quite as well as I have in the past, or I've been, you know, misplacing my keys or something. And I'm really worried because, you know, my mom or father, somebody had dementia, and I'm worried that this is happening to me. So I hear that with people coming to me, but that's often not dementia. So to begin this talk, I start with that example because it's very important to talk about what dementia isn't, likely more so than it is to talk about what it is. So when individuals come to me with a memory issue, memory impairment, what we want to talk about are what could be the cause of that. So if someone's saying, hey, I'm not remembering things quite as well, then there's a list of questions and some things we need to do beforehand that really leads us into the discussion of what else could be happening. And this is really where the time invested comes into play. Oftentimes, what I find is that a person has what we call delayed recall, meaning that you forget about it, but you later remember it. And as it turns out, that's pretty normal. And that's great because we can say, oh, all right, reassurance, right? This is something that you come to expect. Say that, you know, I forgot what I was going to say when I came in the room, and then, you know, later on, you know, a couple minutes later, I remembered it, but I forgot it at that time. That's a very normal process. What would be abnormal, let's say, in an extreme example, would somebody say, you know, I don't know what the big deal is. I just lose my keys every now and then. They say, no, Mom, you went driving around and you forgot where you were, and we had to get somebody to find you and bring you home, right? That minimization, those huge events, obviously are on the more extreme of it. So what do you do for the people in between that are not the delayed recall and are not the clearly something else like dementia could be happening? There's a list of questions I will go through that include things like, how are you sleeping? How are you eating? You know, what kind of things do you enjoy? How's your concentration, your focus? To tease out if one of the biggest contributors to memory impairment, if it's dementia, if it's depression. So as it turns out, depression is a very common cause of memory loss, and it's a correctable one. And it's not always obvious. So rarely do I have somebody come to the office and say, hey, I'm depressed, right? I feel sad a lot. Yes, it may be there, but it may not be the complaint that I get. Instead, the complaint that I get may be I'm not sleeping well, or you guessed it, memory loss, right? I'm not remembering things quite as well. So going through the proper steps and measures and then saying, okay, well, I think this may be what's happening, and then treating that would be appropriate. We would also look at other causes, such as vitamin deficiencies, B12, folate, vitamin D. We would look for thyroid problems. Yes, the thyroid can be a contributor. We would also look at your kidney and liver functions. It turns out liver disease may be problematic. And we would look at your electrolytes, things like your sodium, potassium, calcium, all these things that affect so many parts of our body that could be playing a role in why we may not be remembering things as well. So let's say we go through all of that, and the kidneys and liver, all that looks good, and our thyroid looks good, and vitamins are all normal, and well, what we're having is something a little bit more than delayed recall. Okay, so maybe dementia is on the table. Still not saying that it is, but there are other things that we may want to be looking at. So whenever we go through this, having some kind of timeline, some kind of course of what kind of issues that person is having on there, whether it be a slow, gradual decline or a stepwise decline that we have, if it's something brand new or something that's been going on for years, we'll tease that part out and then say, okay, well, I feel like this could be what's going on. So I'm a visual person, and I'm going to draw out a few graphs for you today. And so just to show you what I'm going to be doing on here, I'm going to have two lines, a vertical line and a horizontal line. And on the horizontal line is going to be time, and it's going to be going forward, right? Time always goes forward. And then on the vertical line, we're going to have memory. So it's going to look like this. Can you all see that very well?
Yes, looks good.
Looks good. Okay. So I like to be an interactive teacher. So anybody that's on the chat now, feel free to chip in. How do you think that line would look with normally, right? With no dementia. So I'm going to hold this up here just for your visualization. Just get some thoughts. Do you think it would be straight across? Do you think it would slope down? What do you folks think?
I think over time it would probably start going up, right?
Or you mean like start going like up, like the memory's getting better?
Oh no, other way. That memory would get worse over time.
A lot of folks do. As it turns out, it shouldn't. Remember, delayed recall is normal, but your actual memory itself stays fairly stable, right? So if we're having some kind of decline in that, something's happening. Now, let's say that we're going to have that same line. Remember, the memory is on the vertical, time is on the horizontal. So hold up like this. Let's say someone says, hey, we noticed that with Grandpa, right? Often somebody else that notices this, that he was doing fine, and then one day he just started kind of, losing his keys all the time. And then he did fine for a long time. And then one day, he started forgetting why he was coming to the living room. And what you notice is that we're doing fine for a while, and then we have a little bit of a drop, and it keeps going down. So I'm gonna continue drawing this just for the sake of time here. So it looks very stepwise. If I see this is actually not classic of what people think when they think dementia. So when you think dementia, what word jumps in your head almost immediately, right? When I say that term, a lot of people want to think of this particular word. What word do you think it is? Alzheimer's. Bingo, right? People think of Alzheimer's right away. And the big take home of this talk, to get anything else out of it, is that Alzheimer's is a diagnosis of exclusion. Yes, there is a way to formally diagnose it, but you cannot do that while this person's alive, at least not yet. There's all kinds of studies that are out there looking at different types of proteins, what we call tau proteins, all these different ways of diagnosing. But as it turns out, the definitive confirmatory way is on a biopsy of the brain. So it's going to be a diagnosis of exclusion, meaning we've got to exclude. So we've excluded a lot of the things already that could be contributing, but this, as it turns out, would not be Alzheimer's. So typically when I see something like this, where there's been these gradual changes, not gradual, I'm sorry, these stepwise changes, we call that vascular dementia. This can be related to items such as diabetes, high blood pressure, cholesterol issues. Essentially what we're talking about are teeny tiny strokes that are happening over a long period of time. So these tiny strokes don't always give you the symptoms like facial droop and slurred speech. Sure, a big stroke can affect your memory, absolutely, depending on what part of the brain it's in. But the presentation of this may be very different depending on what part of the brain it's in. But these stepwise approaches, again, think vascular dementia. Now hold on to that because I'm going to come back to that in a moment. The next graph I'm going to show you is going to be one that you may have been thinking of. And we call this a gradual decrease, right? There's no stepwise. It's just this line that kind of curves down, right? Slow decrease over time, doesn't really stay stable for a while and gets worse. That is our classic picture for Alzheimer's dementia. If you have that information and you have somebody at home that's been watching us and taking, being able to look at mom or dad or whoever it may be, one of our siblings, that's really helpful to determine what could be happening, and that even helps us say what we do next. Unfortunately, though, that's often not the case. What will happen is that I will have somebody come in when they're more advanced in the memory loss, because until it gets really bad, a lot of people don't think that it's a huge issue unless it's something that they've had personally in their family. So what I've created here is this dashed line. Are you all able to see that okay? On here?
Yes.
Yeah. Good. So that dashed line is about where somebody would come into the office and say, hey, this is what's going on. And unfortunately, as you can tell, if I just go by this dashed line, I can't tell you vascular or Alzheimer's. So having that kind of history is going to be important. And being able to identify things early on and saying, hey, you know what, this is concerning me. I think we need to go and see the doc now. May help kind of tease out, again, I'm using that word, what is happening. So those are two forms of dementia that can look very similar later in the disease state. And they can be treated similarly, and we'll go into that in a moment. But one of the kickers is that this one is preventable. Largely preventable. This vascular dementia, this stepwise dementia. And the reason that it's preventable is because of some of the causes that we talk about all the time when you come to the doc. High blood pressure, cholesterol issues, diabetes, the importance of controlling blood sugars. That's right. These things, if left unchecked, can develop into a memory impairment later in life. So we tend to think, okay, well, it's going to be a big heart attack one day or a stroke, but it turns out that's not often the case. This is something that I have been seeing an increasing amount of. Once upon a time, I was in Corpus Christi, which is one of the more obese cities in the country. And obesity, of course, you have diabetes and blood pressure and cholesterol issues. So we saw this often, more often than we did Alzheimer's. And that made it very difficult to say what was going on to be able to treat it appropriately. If you get brain imaging, like a CT scan, which is kind of like an X-ray. It's like 11,000 X-rays. Think of it like that. That helps slice up things so I can look at different parts of the brain. I can actually see those teeny tiny strokes that are happening long before a person even gets memory issues. If I happen to get that imaging for a different reason. So I want to back up a little bit. We talked about vascular dementia. We talked about Alzheimer's dementia and how they progress, right? And they are progressive diseases, so both of them are going to be defined by gradually getting worse over time. But they're not the only types. There are other types of memory issues that may point us in a direction different than these two. There's some like what we call frontal temporal dementia, and this one is one that is common in families that tends to get overlooked. This is the Thanksgiving dinner you have, where you have the relative where you know, hey, maybe their memory's not great, but they're saying some things that are wildly inappropriate on there. So it's a frontal lobe. Yes. So are you mentioning talking about the starting at the Thanksgiving dinner, Miss Nelson? Okay, good. So what I was alluding to there had to do more with an individual that may be saying things that are wildly inappropriate, right, or acting in ways that are just not quite right. And, sometimes it can be pretty funny, and this is where it gets. It is very important to be able to recognize where our normal behaviors are, and to be able to say, okay, you know what, this isn't like Uncle Bob. He's not like this. He doesn't say things that are just, that are non-PC. He's always been a PC guy. That is what we call a frontal temporal dementia. So frontal lobe dysfunction has to do with our ability to do things appropriately, not say things inappropriately. Let's say that we go to dinner and we're not. Okay, so it sounds like that we're still having difficulty with the audio.
I think if you just keep your head up and not, when you put your head down, we tend to have trouble hearing you.
Oh, okay.
Yeah,
I'm
yeah.
putting my head down to be able to get closer to the speaker. How about now?
Go ahead and talk.
Okay, so I take it this is going to be a little bit better now.
Yes, thumbs up.
Good. Fantastic. All right. And again, thank you all for letting me know. That tells me we're all very engaged in this, so thank you. So the frontal temporal dementia is, again, disinhibition, right? A person that's inappropriate language or behaviors. That would tell me that something else could be happening. Typically, though, that's a gradual memory loss, but the people that have that tend to be younger, meaning less than 60 years old. So if you come in 80, could it be a possibility? Yes, but I'm going to be thinking more Alzheimer's if it's gradual than I will be there. The other one to think about is what we call Lewy Body dementia. And Lewy Body dementia can not always, a component of what we call Parkinson's disease. And I'm sure there's been so much media out there about Parkinson's that a lot of folks are familiar with some of the signs and symptoms of that, such as our, the classic tremor, the mask-like face, the rigidity, right? But there can be an associated dementia. Lewy Body dementia tends to be gradual, like Alzheimer's, so that straight curve that goes down. But the difference there is that there's often hallucinations. And when I say hallucinations, I mean very vivid, very well described hallucinations. I had an individual once, for example, that would be, they would be in the office with me, and all of a sudden they would grab their chair as if the ground were shaking and say, I think a plane just crashed outside. And they could describe the plane and the heat. They could feel the vibrations. So very visual, very detailed hallucinations. They don't all have to be horrific like that, nor do they have to be related to something in somebody's life. But it's something that's clearly they're seeing in detail that you are not. So to recap, gradual stepwise decline, what we call a vascular dementia. That means it's more related to blood vessels and blood flow problems. These gradual declines, if there are hallucinations, it's what we would call a Lewy body, that's L-E-W-Y, body dementia. If there are these disinhibition, this either vulgar language or inappropriate actions, and very often if they're under 60 for this gradual decline, that's frontal temporal dementia. So there's a lot of types of dementia out there, and even saying which one it is. So if it's gradual, not stepwise, if there are no hallucinations, and there is not a lot of this inappropriate behavior in a younger person, then we're likely dealing with Alzheimer's dementia. So as you can tell, there are a lot of steps to get to that point of saying that somebody has a true Alzheimer's dementia. And even then, the only reason that you're calling it that is because you've ruled out everything else. So then that leads us to the next often question that I get, and that's, how do you treat it? And this is a very difficult discussion because oftentimes, if a person is presenting later with a high severity, there's not a lot that I can do in terms of. So there are different medications out there. They all say they all, but they often work in slightly different ways with different goals. But the overall theme of those medications would be to slow the rate of the memory loss. So that means that if you're already at that end stage, you're already there. There's not much that you can slow on that. But if we're very mild, then getting on a medication to where you can slow that process down may be of great benefit. Buys more time with your loved ones. But it is a gradual disease, and so that's important to know. The other question that I will get a lot is, what do I do if somebody with dementia, especially in those later stages, gets aggressive or gets violent? Because that happens. Even with the sweetest of people, it can happen. And often people will come to me wanting some kind of pill to be able to do that. Some of the more often requests that I will get will be, hey, can you give her something, or him or her something to help them sleep, or something to help relax them. And what's important to know about a lot of these medications is that they may help a person that is not typically with a dementia process, but with a person that is older or a person that has any of these types of dementia that I mentioned, it may worsen those problems. That's right. So, the classic Xanax, for example, is one that I hear. Can you give them some Xanax or something like that to help them relax? I would not recommend that. It may make them more agitated. It may make a person more confused, more likely to fall, which could cause them to break a hip, which could be life-threatening to them. The other options, some individuals will say, I heard that this medication called Seroquel helped for sleep, or, something for, they're quite frankly, they're getting psychotic behavior. Can we have something for that? And unfortunately, some of those medications also may cause stroke. Yes, so this discussion includes the treatment of Alzheimer's dementia. That is correct on there. Some of these types of dementias are treated similarly. But when we talk about when we're talking about the treatment, yes, right now I am focused on the Alzheimer's component. Vascular dementia, you can use one type of medication that is similar to what you would use with Alzheimer's, and that is called Aricept. It does tend to cause dizziness, and a person that has vascular dementia may already have dizziness. And again, the goal would be to slow it. So if we're talking about vascular, it may be more appropriate to talk about decreasing their risk factors, treating the blood pressure, the diabetes, the cholesterol issues, and so forth. May provide you more benefit than the medication to slow it. Though there is some evidence to say that you can use a medication like Aricept in vascular dementia. But to clarify that question, that is correct. Alzheimer's is the focus of this medication discussion. But unfortunately, as you just likely heard me explain there, there's not a good medication, especially as we get in later stages of these problems. Some of the best treatments will be what we call non-pharmacologic treatments. As a geriatrician, I got to tell you, I hate giving patients pills. I think that medications, they have a time and a place, but they often cause more harm than good. And if you look at what causes a lot of the health problems in society today, it's the medications themselves, even more than some of the health issues that they were dealing with initially. So we have to be very judicial about medications that we use and realize that they all have potential for side effects, and that we have to weigh the risk and benefit of using those medications. And some medications, as it turns out, for other diseases may actually increase your risk of having memory problems, including dementia. You may have heard about this on the news or through some secondary source, but medications such as what we call PPIs, heartburn medications, Protonics, probably heard about it, is Prilosec or Zantac, may interfere with the absorption of certain nutrients you need, like B12. They may lead to certain types of dementia. Other medications that are notorious for doing that would be allergy medications, Claritin, Allegra, Zyrtec. They're great for treating allergies when you have those problems, but using them long term may increase your risk of having one of these types of memory impairment, particularly the development of Alzheimer's dementia. Another one, besides the Zantac and, besides the antacids and the heartburn medications, would be a medication that we'd use to help with bladder leakage. Commonly, physicians will use a medication called oxybutynin. A lot of those types of medications that help with bladder leakage and overactive bladder may also contribute to the development of dementia when used long term. So again, being very judicious, not just with the use of medications for dementia, but the use of medications for other problems. Using them for the lowest possible dose for the shortest amount of time is going to be critically important for prevention's sake. Non-pharmacologic treatments would include reminiscent therapy. That's one of the ones I found to be most effective. So what does that entail? It can be a large range of things, but the idea is to be focused on items that help that patient become relaxed, whether it be a family photo from a time that they enjoyed, a blanket that they really love, more commonly music. It turns out music from when they were younger, the kind of music that they love, may reactivate certain parts of the brain that have been slowed down because of their ailment that they have. So there was a good YouTube video I saw years ago where they were playing music from when they were in their 20s and 30s, and there was an individual that, he never talked, right? He became very non-communicative, and he listened to music for about 20 minutes and then started yammering away. It was pretty cool. But I have found those things to be helpful with people. Environment modification, as I mentioned, making things just as much at home as possible, and then being around family, which is becoming increasingly difficult during these times. This is usually the point where I stop because I want it to be more of a brief overview of the different types of dementia, what it's not, what it could be, some of the things that we try, some of the things you shouldn't try, some of the things you should prevent. So we've very rapidly gone over those items. I'd like to open the floor to any of you folks to ask what you want to ask. It doesn't even have to be about dementia. If there's something else that's on your mind, I'd be happy to help you with that too.
We've got 2 questions. Let me go ahead and actually we've got 3 now. So if I could ask them, if you get a brain scan and determine TIAs and mini strokes, is there something to do about that or prevent worsening, getting worse?
Absolutely. So 2 parts to that question. Let's say that we find this very early on, right? Especially TIAs are very obvious to a lot of folks. TIAs can be things like sudden vision loss that comes back, for example, or even strokes themselves are more obvious. And then it's going to be the same treatments that you would use to help prevent another stroke. So that may be in a person that benefits from aspirin. Not everybody does, but some kind of blood thinner in the folks that would need that. Cholesterol medications obviously are going to be key at preventing worsening of any plaque buildup, for example, controlling risk factors such as high blood pressure and diabetes to prevent the worsening or recurrence of those problems. And then when we talk about the gradual decline in memory, is it appropriate to try something like Aricept? That's generic is donepezil on there. Those are also appropriate, again, based on the discussion in the clinical setting. This is something, obviously, when I sit down with my patients, we discuss every option that they have and to come up with a plan together. But a very good question. It's going to be about prevention of the other risk factors that person has. And then we can also talk about the possibility of something to delay any memory progression if felt needed.
Great. Another question is, those last meds that you were talking about, the issues mentioned about the downside of medication, didn't understand the condition. So I think I'm not really understanding that question. Do you understand it? Those last meds and issues mentioned about the downside of meds, didn't understand the condition. Mary, maybe you could restate that, because I'm not understanding unless you do. Do you understand, Dr. Purtle?
I will attempt, and if I don't, feel free to cut in and say, hey, this is the actual question that I had.
Okay.
I believe this had to do with a question that was focused at the treatment of Alzheimer's, and was this focused at Alzheimer's, or was this focused at one of the other types of the dementia that we were speaking of on there? And so the treatments of some of Alzheimer's and what you would not do, that was focused at Alzheimer's, but it was actually focused at anybody with any of these issues, especially over the age of 65. So the medications like the anti-anxiety medications, the sleep medications, those you really want to avoid in general, regardless of what type of dementia that we're dealing with. To really use a better statement to, say, just do not use. I often don't find them helpful. Even in the absence of dementia, we may be taking big risks.
Okay. Are your services covered by Medicare, and do you need a referral from another doctor?
Okay, so I am a Medicare physician, so I do accept Medicare. We also accept Medicare Advantage plans on there. I am a primary care physician, so I do not require a referral. I am a specialist in geriatric medicine, but I am still a primary care doctor. This is simply a passion, a love of mine, and a focus of mine. Certainly, WellMet allows.
So if somebody needed, oh, sorry about that. If somebody needs to have a referral, let's say for for a surgeon, do you have to refer them, or can they just call the surgeon?
So what I would prefer is to have that discussion in the office to say, what's going on, right? So sometimes it's not a surgical issue. Sometimes something else could be happening. Let's say it's like for a knee issue, right? There's often other things we can try first without exposing ourselves to the risks of surgery. But with that said, if it is a surgical issue, yes, I do refer out. Now, the other benefit that we have here is that we have relationships with different physicians in the community. And these relationships are not based on just, hey, I really like this guy, they've got a great personality. Instead, what WellMet has done is they've created this portfolio of all these different healthcare providers in the area and what kind of quality of care that they give the different patients, whether they be an ophthalmologist or an orthopedic surgeon or a neurologist or a cardiologist. We actually know who the best ones are, and we keep up in real time with who they are. So it's not just who would I give you that referral. The goal would be to give you the referral to the one who's going to be providing you the best care. And if you didn't feel that way, that's good for us to know, because we can update that portfolio and say, hey, maybe, we don't want our patients to go there if they're not being treated well. But oftentimes we find that the individuals that we've selected, they work very well for a reason, because they're good to the patients and they're providing the good care. And that's ultimately what we want.
Can the medications to treat one type of dementia worsen other types of dementia? That's an interesting question.
It is. And the answer is yes, it can. As it turns out, treating some types of other health issues can do that too. The Lewy Body one is a very common one, right? So this is one of the more challenging ones. So to review, Lewy Body is a gradual dementia that's similar to Alzheimer's, often associated, unfortunately, with Parkinson's disease. So if you're treating that Parkinson's ailment of it, you can worsen the hallucinations that are associated with the Lewy body. So there often is a very challenging balance that you have between those two. If we hit that wall, I will coordinate care with a neurologist during that time to make sure that what we're doing is safe and best practice.
Great.
So, but an excellent question. Yes, you may worsen some components of dementia by treating either another type or another disease.
Great. Somebody is asking about a specific kind of medication. I'm going to spell it. MEMANTINE.
Yes. So how can I help you with
Just
that question?
just describe that medication and what it might be used for. In what case might you use it for?
Okay, so this one's one that has been used with Alzheimer's dementia. So the trade name for this one, and the one it's best known as, is called Namenda. And so Namenda is one that is typically less tolerated than the donepezil, which is the Aricept that I mentioned earlier. It tends to cause a bit more dizziness and a bigger fall risk. I usually will use it as an adjuvant, meaning with the Aricept, though it can be used by itself. It does not have any good data to say that it works with other types of dementia, like the vascular dementia. In fact, there's been some really good studies to say that it doesn't. So with that one, because of the constipation, which is another problem, because of the dizziness that it causes, I usually reserve it, and usually in combination with something like Aricept with it. I don't know if that answers the question.
Yeah, that's great. Super. Okay, so this question is satellite office in Austin proper. You're a little bit far to come to Lakeway. So are there other WellMed locations that people can go to and find a doctor who has the same kind of services that you provide?
Yes. So WellMed is huge. And WellMed has a, I guess you'd say, a partnership with United Health Group. So there's all these resources that are from them as well, and there's a huge outreach. WellMed is not new. It may be new to some of the ears on the video today, but WellMed has been around for 30 years. And it has an extensive outreach starting from San Antonio all through Texas, now all through Florida and New Mexico. We have multiple offices in different cities, including this one. So depending on the area of town that you're in, there should be a WellMed office nearby. I know that Lakeway can be a bit far out unless you live in this area, and not everybody that I see, in fact, a lot of people that I see, if they had to drive a lot, that would be a real challenge for them to be able to make it here. So we recognize that. We have locations, a huge clinic in South Austin off of Ben White. We have clinics in the Austin area that extend down from San Marcos all the way up through Georgetown, even some in Leander. We have some in East Austin, Midtown. Really, I would say, look, with the map, I'd be happy to help guide you in a direction that would be good for you.
Great. This is a really interesting question. Is it worth getting some kind of testing to determine a baseline to judge any kind of decline? Yes,
there are different ways that we're able to do that. And this is something that I do practice myself. The two that I will often use, I'm a big fan of what we call the mini cog. You may have heard something similar about that on TV with identification, right? Man, woman, person, camera, TV, that thing. So that kind of study, or one that we call the mini mental state exam, which is the MMSE. That one I've used too, as well as what we call a clock draw. If I use this, I can actually say, okay, well, let's say that your memory, you don't think it's great, but you're not really trusting that it's depression or thyroid or something, right? You want to see if it's changing over time. That's a very appropriate thing to do. Usually in those cases, I'll do it every 6 to 12 months, depending on the clinical aspect of it. I think 12 months is a good time frame to monitor unless there's been a big change. But I do find some utility in that. It's really going to be case to case on when I would use that.
So let's say you're not showing any signs of Alzheimer's or dementia, but you want to get a baseline. Is it something that would be approved to have the test be taken, or would it be hard to get that test approved? Do you need to be showing a symptom before you can actually get that? I guess I'm just wondering about cost, et cetera.
No, so it does, that there is a screening tool that we use that I haven't had any issues with patients being able to get it covered. In fact, that's one of our new patient assessments is by use of that. And a lot of our Medicare Advantage patients will take advantage of that assessment, and something that we do on a yearly basis now. Well, good.
Terrific. It seems like sometimes you're fighting, to get these tests approved, to be covered. Yeah. Okay, so this is actually around the bladder, and I found that interesting too, where you were talking about the side effects of the bladder medicine. So a lot of as we age, a lot of people have nighttime urination problems and other problems like that. So taking that medicine really allows people to have more freedom, but yet if you're taking that medicine and it potentially could be leading to having some kind of dementia problem, you really got to weigh that. So tell us a little bit more about that. Good.
So not an uncommon question, and a little bit of hesitation that I myself get when having these meetings in the office, because that one's one that makes a huge life difference. So when it comes to certain medications for overactive bladder and incontinence, not all medications are going to have that risk, right? The more common ones, and unfortunately, some of the more affordable ones are going to be the ones that cause that. So in those cases where it's really a matter of, okay, this is the medication that I can afford to take, cost is an issue, right? And I can't get good coverage of an alternative, then we're going to weigh the risk and benefit, because quality of life matters, right? This would say that this is a problem that we know that we have versus a problem that we may or may not get from this medication. It's not guaranteed that you're going to get dementia just because you took that medication. It just means that your risk is going to be higher of those problems. So what we want to do ideally is look at alternatives to the medications like oxybutynin that cause problems with dementia, but may be good at treating issues like incontinence, and look for the alternatives that work differently that accomplish the same goal. One of the ones that I found to be very effective is a medication called Neurometric. Again, I'm not any kind of pharmaceutical rep. I don't have ties to any kind of medication. It's just one that I find to be helpful, that I cannot wait for it to become generic because it works differently. It works more as a bladder, think of it as a bladder wall relaxant, easy way to explain it. But it doesn't have those same effects on the whole body that medications like oxybutynin have. It doesn't increase your risk of dementia. So that's an option. Urologist.
Spell that? Can you spell that?
I'm going to be better if I write it. It's going to be MYR.
Okay, go closer to your mic. We're having trouble hearing you.
Okay, how's this? Is this better?
Good. Yeah.
Actually, here's what I'm going to do. I'm going to put it in the chat box here, okay?
Oh, great.
So
Super.
give me 1 second here so I can get a few more set up. Okay, so it's going to be. Okay.
Thank you. Oh my goodness. There's no way I could have written that down.
Yeah.
Terrific.
But that's one.
So we have another question. Oh, yeah. I'm sorry.
Oh, go ahead.
Okay. Great. Oh, we cannot see it. Oh, you sent it just to the panelists. That's okay. I'll make it active to everybody. Yeah, I'll make it. I got it. I'll have you answer the next question. Or I think you were going to talk about a second medication that might work.
No, the other suggestion was to visit with a urologist. There are other options. Let's say that the oxybutynin was causing issues with dizziness. Now, it's not just like the concern of memory impairment. Let's just say we don't want to use it, and the Neurometric didn't work, right? Sometimes that happens. There are other options. Some will consider things like Botox injections, for example. But really, this is a discussion for the urologist when we get to that point.
Excellent.
I retyped it, so hopefully people can see it again. I
Yes.
just changed where it was to.
Yeah, that's great. Okay, so here's another question. It's about allergy medicines.
Okay.
So once you get in your 70s and 80s, should you stop taking allergy medicines such as Singular or try to avoid it?
So Singular is going to be okay. That one I don't see a lot of issues with. The ones that I have seen more issues with the development of dementia are going to be more with those strong antihistamine kind of properties, like Zyrtec, Allegra, Claritin. The Singular, I'm not aware of any data to say that it's necessarily really bad. It may be, just that I'm not aware of any current data on that. So thank you for that. Very important question. I do use Singular for a lot of my patients with persistent allergy issues. The important take home from that is to avoid a lot of the over-the-counter allergy medications because there may be more risk than benefit to them. That are the pills like the Allegra, Claritin, Zyrtec. Use those less frequently and focus on different times. There's some good studies to say that there are different medications you can take for your allergies that don't have those same risks that may actually help you more than what you're taking over the counter. And one of those is Flonase, and I'll write that one out for you here too, which does have a generic, which is fluticasone, and you have that on there. It's a nasal spray. It's a steroid. It's a nasal steroid, so you should not be getting those full body effects in the same way that you would have if you took an oral steroid. And the idea is to decrease some of that inflammation in those upper airways that are caused by allergies to prevent some of the drainage issues that you may have. So it has been found to work better than a lot of the oral over-the-counter medications and did not work better if you added them to it. So that's one option that you may have. But in terms of Singular, that one's the one I usually will go with if the Flonase isn't as helpful.
Great.
But
This is a great question.
Yes, it's an amazing question, actually. That's a very good question. So good.
Do you have to be 65 to go to WellMet?
No, we do. My understanding is from WellMet, these are not my decisions on this. This is more from a corporate level, that it's Medicare and Medicare Advantage.
Okay, terrific.
But
what is your opinion? Yeah, it is. What is your opinion of the OTC meds for memory loss advertised on TV?
I don't have a good opinion of them. There are different ones out there. They're coming out all the time. I haven't seen any good data on them. I would say use caution. A lot of those medications are marketed as herbal supplements, and they can bypass a lot of the FDA regulations as a result of that. And this isn't to get on the back of the FDA, but the FDA does do a lot of good things, and some of that has to do with safety data and interactions with medications, other medications on the market, and other disease states that a person may have too. And that data may not be there with some of those other herbal medications on safety or efficacy. So I would use caution. So I can't say that they don't work, but I would use caution on using them, and I typically recommend against it, secondary to it may interact with other medications we may be on.
Okay. What do you think about taking allergy shots? Is there the same kind of risk as the over-the-counter allergy products? So could you get allergy shots and then you wouldn't have to take the medicine, obviously. But is there a risk to the allergy shots as we age?
That would depend on the medication that we receive. A lot of people that receive allergy shots, so to speak, are receiving steroid therapy, essentially, which should not be as a big risk as taking something consistently like Allegra, Zyrtec, Claritin. Usually those would be more short term, but I guess it depends more on the medication to be able to answer that honestly with it.
Okay.
But I would say that taking an oral pill over-the-counter daily antihistamine is a big risk and that I would not take.
Excellent. So somebody's asking about another nasal spray, and if it's risky, I cannot pronounce. I'm so sorry. I'm going to have to spell it for you. IPRATROPLUM, bromine.
Yes,
What is
and
that risky?
I've started seeing a lot of ENT docs, that's your ear, nose, and throat docs, use that one. No, that one should be okay. There are risks with that medication, as there are with all medications, but when it comes to the development of dementia, no, that one should be a safer one to use for that purpose.
Great. So tell us, I've been reading now that we're having people who are having heart attacks and who have all these health issues that they're not taking care of because they're afraid to come to the doctors. So tell us about the safeguards that you have in place for people when they come in to visit you, because sometimes you just have to be in person.
Absolutely. That is absolutely true. Obviously, you know, I do Medicare Advantage, so all of my patients are going to be high risk. It's not just some of them, all are high risk. So we have to treat it as such. Every one of our staff that will be in contact with you should be wearing a mask, a face shield, gloves. We have very strict hand washing procedures that are in place. So we follow all the guidelines and regulations that are in place for patient safety. But again, that would just not be enough for us. We have to be that person that goes above and beyond. So remember at the beginning of the conversation, and for those that join later, we discussed the use of this technology called GrandPad. And what we will do is minimize that face-to-face part of the conversation to the maximum amount that we can to limit the amount of exposure a person takes. They can use one of these pads in their vehicle. They can use one of these pads in what we call a negative pressure room, and I can go into that in a minute. But the idea is that we know that individuals with COVID and other infectious diseases, that a lot of the spread, the contagion, a lot of it has to do with exposure time. So if we can limit that exposure time, that could be huge. And so that's one way to do it. We also navigate it to where we have one patient in our office at a time. This is new. Again, we've had to be innovative. Not all WellMeds are going to be able to accommodate that, but there are ways that they have it to prevent a full waiting room and have a streamlined process for patient safety. For here, I can speak that we have one in the office at a time. That means alternating with telemedicine visits while other individuals are being worked up or taken care of. The negative pressure room is part of our facility. The idea is also to help minimize spread, not just within the building, but within the room itself. It's designed even to limit contagion from individuals with influenza and even tuberculosis, for example. So it's a great resource to have for us. We even go and draw blood at the car. There's some folks that just don't want to come in through these glass doors. I come to you. I do that too. For those that are like, Doc, I really don't even want to get out of my car. I'm scared. And I understand. I don't want to miss something huge because of being scared. So I want to give that opportunity. I will mask up, gown up. I wear goggles. Obviously, step away. Even have this nice little face shield. I promise it's not riot gear. It's just to prevent that spread part of it. I will come to you and listen to heart and lungs, everything from the car, if that makes you feel more comfortable. But we have all kinds of means to be able to help ensure safety the best as we can.
Well, this has been fascinating. We are so thankful that you were able to come and talk with us today and talk about dementia and answer some other questions that people had. I know I wrote down some notes of new things that I had never heard before, and we really appreciate you taking time out of your day. I know it's tough since you're a one-doc shop, and we so appreciate it. I wanted to let everybody know that this video will be on YouTube, so if you have friends and family that you'd like for them to hear, or you want to come back and listen to it again, We have a YouTube channel. It's LT Senior Services, which sounds so fancy. We're just getting so fancy now. But you can rewatch the video. I want to thank everybody for attending. We had close to 50 people on the call today, and it's just so great to have everybody come. We really wish we were in person. The intention is to get back in person, but we're doing the best we can, and we appreciate everybody learning the technology, getting on today, and we look forward to seeing you at our Wellness Expo on October 1st. And thank you again, Dr. Purtle, and thank you, WellMed, for sharing him with us today. We are so appreciative. Have a great day, everybody.